The surgery was pre-approved.
The insurer confirmed it in writing.
Then the patient bill arrived. $74,000.
Both facts could exist at the same time, because authorization is not a price guarantee.
In this dramatized composite, an itemized audit, the plan documents, and federal surprise billing protections reduced the patient responsibility to $2,800.
Maya Carter planned the procedure weeks in advance.
Her insurer's directory listed the hospital and surgeon as in-network.
The surgeon's office obtained prior authorization, and Maya saved the letter, reference number, procedure, and date range.
She checked her deductible and expected co-insurance. What she did not receive was a complete list of participating clinicians. A hospital team can include anesthesia, assistant surgeons, pathology, radiology, and laboratories that bill separately.
The procedure and recovery went well.
Then envelopes arrived from organizations Maya did not recognize.
The facility statement appeared to use out-of-network cost sharing.
Another bill came from an anesthesiology group Maya had never selected.
The EOB listed separate claim numbers, allowed amounts, remark codes, and patient responsibility.
An EOB explains claim processing. It is not a provider bill.
But when Maya matched the EOBs with the bills, the combined amount attributed to her was $74,000.
The authorization also warned that approval did not guarantee every condition for payment. Prior authorization generally means the plan reviewed a requested service under its medical necessity and coverage rules before care.
Healthcare.gov explicitly warns that pre-authorization is not a promise the plan will pay every cost.
Eligibility can change.
Coding can differ from the request. Deductibles and co-insurance still apply. A facility and each clinician can also have different network status.
Authorization was still valuable evidence. It identified the approved service and contradicted parts of the later processing.
But it did not replace the plan document, provider contracts, final claim, or federal and state billing protections.
Sam asked for the itemized bill from every provider and the matching EOB for every claim.
They built a simple table: date of service, provider, billing code, billed charge, allowed amount, network status, plan payment, and stated patient share. They checked the EOB remark codes and compared the provider bills with Maya's medical record.
A total is emotionally powerful, but difficult to challenge. A specific duplicate line, network classification, or cost-sharing calculation can be investigated and corrected.
The audit found 3 different issues.
First, one supply appeared twice on the facility statement, so Maya asked the billing office to verify the duplicate against the medical record.
Second, the in-network facility claim had been routed using out-of-network cost sharing, even though the directory, authorization, and plan documents pointed the other way.
Third, an out-of-network anesthesiology group had billed Maya after providing an ancillary service during a scheduled procedure at an in-network facility.
Each problem required a different recipient and request.
Combining everything into one angry phone call would have made the file harder, not easier, to solve. Since January 2022, the Federal No Surprises Act has generally protected people in group and individual health plans from certain out-of-network bills. For most covered non-emergency care related to a visit at an in-network hospital, hospital outpatient department, or ambulatory surgical center, patient cost sharing for protected services cannot exceed the applicable in-network amount.
Anesthesiology is an ancillary service.
Federal guidance says an out-of-network anesthesiology provider generally cannot ask a patient to waive these protections through notice and consent.
The law does not cover every plan, facility, service, or billing problem, so Maya still checked the facts. But this was the exact kind of network surprise the law was designed to address. Maya sent 3 focused requests. The facility received the suspected duplicate line and a request to compare it with the medical record. The insurer received the authorization, directory evidence, plan pages,
and a request to correct the facility's network status and cost sharing.
The anesthesiology group received notice that the service appeared protected by the No Surprises Act and a request to stop balance billing activity during review.
Maya used secure portals and trackable mail, saved every confirmation, and requested written responses. If ordinary claim correction failed, the EOB and plan documents described the formal appeal route and deadline.
Maya was prepared to file an internal appeal, identifying each adverse decision, the requested correction, and every supporting document.
External review is not automatic for every billing disagreement, but many plans must offer independent review for eligible adverse benefit determinations. No Surprises Act decisions also have appeal and complaint protections.
Urgent care timelines differ from post-service payment disputes, and some employer plans use federal procedures instead of a state process.
The practical rule is simple. Follow the appeal instructions on the denial or EOB, meet the deadline, and keep copies of the complete submission.
Jurisdiction can look confusing.
State insurance departments commonly handle fully insured plans.
Many self-funded employer plans fall under federal ERISA oversight through the Department of Labor.
No Surprises Act concerns can also go to the Federal No Surprises Help Desk.
Maya did not guess. She checked the plan documents, called the member services number, and used the official help desk to confirm the correct channel.
One organized file traveled with her: authorization, directory screenshots, itemized bills, EOBs, plan pages, letters, delivery confirmations, and a dated contact log.
In this composite, the facility removed the duplicate, the insurer corrected the network processing, and the anesthesiology balance was limited to the protected in-network cost share.
6 weeks later, Maya's responsibility was $2,800, the deductible and coinsurance described by her plan.
Nothing was secretly forgiven.
Different claim lines were corrected under different rules because Maya separated the problems, documented each one, and used the proper protections.
If a large medical bill arrives, keep every authorization and network confirmation.
Request itemized bills and matching EOBs. Compare dates, codes, allowed amounts, network status, and patient share.
Check No Surprises Act protection when an out-of-network clinician treated you at an in-network facility.
Dispute each error in writing before the deadline.
If unresolved, follow the plan's appeal instructions and use the correct state or federal help channel.
Next, on claim denied, storm damage was covered until the file used one different word: flood.
Subscribe, because the fine print does not explain itself.